for me to listen to Dr. Chauhan first, because he has said everything which I wanted to say. I don't have any words to add further. As we are going to have a CME from Dr. Reddi, who is not only a very good neurologist but very good human being. I have found him always helping to my patients. And to tell you something which is, I don't know many people know or not, he has been sending many poor patients to me to get them admitted in my hospital where the prices are low, so that they can benefit throughout the treatment, where he also tells me what to give, what not to give. But I feel very proud to introduce Dr. Reddi today in this CME, who is a very good human being and one of the best neurologists in my words. Sir, without taking much of time, I'll ask Dr. Reddi to please take it.
Thank you, sir. Thank you all of you again for having me here. I hope you can hear me. And is the volume all right, sir? Thank you so much. So it's an honor and a privilege to be here again. I think after these 2 years of a very, very difficult time that all of us had, it's a great place to be here on a Wednesday evening, and like Dr. Chauhan said, 783rd. I mean, I don't think that there are many places in the world who can say that they have a group of doctors meeting for the 783rd time in this period of time. So it's hats off to all of you, and I think that it's wonderful to be a part of this group. First of all, I want to thank everybody for being here tonight. I also want to thank Alagun for organizing this. These days it's not so easy to do all this, and they've really gone out of their way. They've bent their back, to try and organize everything in the period of time that we gave them. So I want to thank them also. So today I'm going to talk about this little condition which is migraine, and I'm going to specifically focus on chronic migraine. It will be a very short talk to tell you a little bit about an advancement on migraine. I'm not going to call it a new treatment anymore. I want to tell you that this particular treatment has now been there for over 12 years. It's an approved, FDA approved treatment in the US, in Europe, in Canada. So this is no longer a new treatment, but I still believe that the number of patients who require this therapy are not getting this therapy. So I'm going to just quickly take you through an overview of this condition and try and, help all of you who are seeing patients with migraine every day. Every day, you probably see much more patients a month of migraine than I see. So I'm sure of that all of you are probably seeing much more people. So I want you to be able to identify the right patient for the right treatment. So I'm going to quickly go through a few things. The first is a little bit about history of the use of BOTOX in chronic migraine. Now, I don't know whether this is large enough, but just to tell you that as long back in the 1920s, BOTOX was first discovered. But it took almost 50 years for it to be put to a scientific use. And it was first used in strabismus, it was used in squint. And while they were giving it for the squint treatment, they noticed that the lines actually disappeared on the forehead. And they said, look, it probably helps in removing wrinkles also. So, over the next few years, BOTOX was acquired. It was first called Botulinum in the 1970s and 80s. It was acquired by Allergan early 1990s. And after that, it has been approved for a host of indications, including strabismus, including cervical dystonia, including these glabellar lines that you can see here, for hyperhidrosis in the axilla. So many people, women who are going for parties in the US would inject themselves so that they don't sweat in a party. And subsequently, in 2010, it was approved for both upper limb spasticity as well as chronic migraine. So that was as long back as 12 years ago. So I want to tell you, this is no longer a new treatment. So what is BOTOX? BOTOX is basically a formulated drug product. It contains an active ingredient surrounded by a certain amount of proteins which kind of help it from degradation so it can be stored easily. And how did this come about to be used in migraine? So in migraine what happened was people in Bollywood, the plastic surgeons started injecting BOTOX to people who were actors and actresses who were having wrinkles. So these people came back after the injection and said that our headaches are better. So suddenly they realized that this worked for headache also. So inadvertently all these Hollywood stars did a favor to the world by coming back and telling people that my headaches, my migraines are much better after you've taken away my wrinkles. So that's how it was studied. And if I look at today's headlines, the moment you look at today's headlines, and I use this pun, headlines, because these are what headlines are. And if you look at the newspaper, this is what happens to your head. You look at the news today and your head goes like this. So this headlines was how BOTOX was first used for migraine. And when we started using it for migraine, we realized that it really works very well. So as far back as October 2010, the FDA approved use of this agent for patients who had chronic migraine. Now what is chronic migraine? I'm just going to quickly define it to you. Chronic migraine means that a person has at least 15 days of headache a month for 3 months, and out of these 15 days, he must have 8 days of typical migraine in which sound and light irritate you, or when you move you get a headache, and the other 7 or 8 days this can be heaviness in the head. So if you have 15 days of headache for any 3 months of a calendar year, it is called chronic migraine. That's all. So it is defined as chronic migraine, and FDA approved the use of this agent for chronic migraine. It helped in 2 ways. It reduced the number of headache days a month, and it improved quality of life. So both things were seen by using this agent. So I'm going to quickly go into the pathophysiology, a very, very brief, and I'm sure this is very well known to all of you. Why and how does this work in chronic migraine? So we know that migraine is basically, an interplay between the environment and the genes. So you have an environmental stimuli which causes some disturbance. Certain things start happening in the brain, as a result of which people start getting headache. So what are these things that happen? There is an activation of the trigeminal-vascular afferents. These are projected into the brainstem. There are certain neurotransmitters which are released. The neurotransmitters result in vasodilatation. This results in extravasation of certain substances in the brain in various areas that are pain sensitive. And these pain structures, these are pain modulating structures, start causing more and more pain which is perceived as migraine. That's the story of migraine in terms of the pathophysiology. And this is, all the chemicals that are there. There is nitric oxide, there is vacuoactive intestinal peptide, acetylcholine, CGRP, which is calcitonin gene-related peptide. There is, other things like substance P and all that. I don't want to go into the details of all this, but just to show you that there is an activation of the afferents of the trigeminal neuron innervating the meningeal blood cells. This results in activation of second order neurons. This projection to the brainstem. Now the brainstem has inhibitory influences. There is brainstem tends to suppress pain. Now those areas are inhibited. This results in a cascade of pain. So how does BOTOX help? And I want to show you that how do you first get chronic migraine? There is inflammation. There is signals going into the brain. There is a release of these excitatory neurotransmitters. There is tissue damage, which results in additional activation and more pain. So BOTOX, what it does is, it causes a cleavage of a SNAP25 and impairs the synaptic vesicle from going out and actually causing a chemical or downstream effect does not happen. So this is both in the motor as well as the sensory system it acts. And I'm going through this very briefly. The moment you give BOTOX there, the downstream effects stop happening. So you have no release of all these CGRP, substance P, etc. there is no peripheral tissue damage, and hence central sensitization does not happen. So all these things that you see where the pathway of migraine is BOTOX inhibits release of these neuropeptides, causes reduced neuroinflammation, it reduces peripheral sensitization, and hence reduces central sensitization. So this is the pathophysiology of migraines. I don't want to go into too much in detail about it because really it's not something which would interest a lot of people here. So how do we get to the point that this actually works? So the landmark trial is a trial called the PREEMPT, okay? And these were phase 3 studies of patients with chronic migraine. There were 122 sites across North America and and Europe. So 106 in North America, 16 sites in Europe. And this is a 32-week open label trial. 155 units of BOTOX was used. Additional 40 units could be administered along with that. Now this vial of BOTOX is of 2 vials. One is a 100-unit vial, a 50-unit vial, and also a 200-unit vial. So the 200-unit vial is what we used. And this was injected into these various areas where we know the nerves which are responsible for actually perceiving and starting the process of migraine. These are the different nerves. You have the supratrochlear nerve, the supraorbital nerve, the auriculotemporal nerve on the temporal areas, the greater occipital and lesser occipital nerve, and the cervical rami. So these are in the trial. You can see BOTOX and placebo. By and large, these are before BOTOX and placebo. Both the groups are very comparable, and it showed that, I'll tell you the crux of the trial, that at least 70% patients have 50% relief. Now when I say that, you can understand here, you're talking about people who have 20 headache days a month. You're talking about people who have 25 headache days a month. If you give them 50% relief, they are down from a 25 to a 12. And then our oral medications and other things may start working. But otherwise what is going to happen here is that these patients are probably getting pain every day on day, and it's like incessant. So you're breaking the cycle of pain. So the number of migraine days per month reduced by an average 8, and the cumulative headache hours on these days also substantially decreased. Now you look at patients here, the headache days and the migraine days, and you can see at week 56, 70% of patients achieved a more than 50% reduction in headache days and migraine days with this medication. Now, one of the problems that we had with these groups was that many of these patients were also taking a lot of painkillers. So this is called a medicine overuse headache. If every day you're taking a painkiller, after some time the painkiller starts causing pain. This is now recognized as medicine overuse headache. Medicine overuse headache is defined as taking more than 10 days of migraine-specific medication, such as vasograin, such as triptans, or 15 days of simple analgesics. So pretty broadly, that's what it is. So if you are out of 30 days, you're taking 15 days of paracetamol or a Cumulative, which you're doing more than. This is called medicine overuse headache. So there were groups of patients who had medicine overuse headache, and in those groups also, headache days and migraine days reduced considerably. So there were hardly any treatment-related side effects. I've been giving this medication for now over 12 years. And let me tell you that, I've spoken about this in various countries, and I've shared the experience that we've had in our subcontinent. And really, there is no side effect, touch wood, I should say that, till date that I can tell you that is worrying. So there were many other additional studies where they used different units. And I'm not going to go into all this. There was in different countries in Europe, they've used these studies and they've consistently found that this works very well. So how do you actually do it? And I'm going to show you a few videos just to show you how I do it in the OPD. And these are the different areas that you target. These are the different muscles. There's the procerus muscle, right? Furrowing the brow, there's a corrugator. And these are the nerves that are impacted when you give this. So you can see, this is how you do it. And I'm saying this is an outpatient process. It takes all of 15 minutes to do. It takes 15 minutes to do, that's all. So there are certain set areas that you will target.
and these are the corrugator muscle, and you will give it into the procedures. And I will not go through the whole video because it's going to take a couple of minutes to play out, so I don't feel that that's fair. But just to show you how this is done, okay? And these are the areas that you're hitting with this injection. The procedures injection is there right in the center, and the patient is not given anesthesia or anything. She's sitting in the OPD. Or you could lay her down on a bed and do it while she's lying down. So it's as simple as that, okay? And there you go, you give it here. Now, these are the frontalis injections. There are 4 injections given at the forehead, and I'll show you the first one. So there are certain landmarks that you follow, and you look at that, and here you measure that out. You're looking at there, so the bevel in this condition, you don't want it to droop downward and the BOTOX to go down. And I'll tell you why you don't want the BOTOX to go down. Because when you do that, if you don't do it properly, these are the sites that you give it. And these, depending on the kind of forehead the person has, you might have to give it here or there. But if you don't do it properly, this can happen. This has never happened. I can tell you that this never happens. As simple as that. None of these medial brow ptosis, or pseudotosis, or liptosis has ever happened. But this is what in the forehead can happen. So now you have the posterior group of muscles. You have the occipitalis, the cervical paraspinalis, and the trapezius. And I'm just showing you the landmarks that we look at. I won't go through the anatomy of all this, but these are the nerves we are targeting. The greater occipital, lesser occipital, and the third occipital nerve. And this is where we give the injections. And here you look at the tip of the ear. You look at the most posterior part of the skull, which is called the inion. You draw a line there. And you don't have to, like I said, no anesthesia, nothing is done. And you're just, there are certain landmarks, and I'll show you that. That's how you measure it. And you get these number of units on each side. Okay? This is the upper cervical paraspinal muscles. Again, you have a certain landmark, you measure that. And I know that, this is just to show you again and again how straightforward and easy this is to do in the outpatient. If you get an appropriate patient who has this problem and is treated, they do so well. You will see how this injection is being given. Okay? And there you go, and that's it. And you get 5 units there. Similarly, you're going to get 5 units on the other side. And so total of 20 units is given in this setting. Okay? So, a total of 20 units is given here. Then you have the trapezius. Again, you have the acromoclavicular joint. You look at the necklace line. Necklace line is, if anybody wears a necklace, that's where it is. You look at this, you look at the midpoint of that, and then between the midpoint and the other points, a midpoint of those you start giving it. So I am not going to again go through. You look at that. So this is the necklace line. This is this, you look at the midpoint of that and you give it. That's all one needs to do, nothing more than that. It's as simple as that. So these are the sites that you give it in the posterior fossa. And now the auriculotemporal nerve. Here you can see again, you give it in a diamond shaped pattern in this area. And you look at the hairline, you go one finger breadth behind that, you can give an injection there. And similarly, you will give it in these 4 points. Okay? And there are extra, so these are the nerves you've covered. These are all the nerves you've covered apart from the cervical vein. And I'm told you that you can give extra injections into certain sites and you can give up to 195 units in a person. And it works very well. So these are the additional, we call it the, if you have tenderness, if somebody has pain in one area, you can give them a little more there. So how do you actually do this? First of all, you have to help people understand that this is a disease. This is chronic migraine. You have to tell people this is not a simple migraine. It's not going to get better with tryptoma and beta cap and cybeliums and all that. This is not getting better with that. So unless what's going to happen is that they're going to have 4 or 5 such medications going on in any prescription. Patient will come, मेरे को महीने में 20 दिन दर्द होता है, and he's got like 5 different prophylactic medications going on in small dosages. Flunarizine 5 milligram, the topiramate, yes. So we'll add that to the list, So you have to tell them that this is a specific type of migraine, and we are telling you that this particular type of migraine has certain medications which are approved, and the number 1 medication for this today is botulinum toxin. So what is it going to do? You've done it very clearly. It's going to reduce your number of headache days per month by 8 to 9. So it's not like magic कि आपने लगा लिया इसके बाद कभी कोई headache नहीं होगा. That's not happening either. So you put to tell them that. The third thing you have to tell them is that the results take about 12 to 24 weeks. So BOTOX is given every 3 months for at least 1 year, but we do not give it up unless at least 2 sessions have been done, and we see with that how effective it is. It's an OPD procedure. It takes 15 minutes for me to inject for 39 injections. So I take about 15 minutes to do that. I mean, after Sumit has loaded it and kept everything ready for me, so I walk into the room and all I need to do is inject it, so it takes about 15 minutes. Less than 15 minutes. I would say about 7 to 8 minutes is what it takes. You will notice, of course, you have to understand that when you're giving these injections, you tell somebody that 39 injections again, you will get 39 injections. It's like a chota sa, like a cheeky biting you. It's not more than that. You never have to give any anesthesia or anything. Is there any side effect? There is no side effect if one needs to burn it out. Is it an appropriate therapy? It has been tried in a multi-center, 122 centers were involved in this trial across North America and Europe. And it is an FDA-approved therapy for this. So, we also want to tell people here that other types of formulation of botulinum toxin are not sort of used for this yet. So at the moment, only the BOTOX from Allergan is actually approved for use for this. So these are the different vials. I'm just sharing this with you. This is a 100 unit vial. It doesn't matter what you take. You take 200 unit vials or one orange vial. What is the cost of this today? I think the cost, including injection charges, roughly works out to about 35,000. And if you get it directly from the company with the help, you can get something off on that. So I know that it seems like a lot of money, but imagine I've had people who are taking Combi-Flams 30 a day, creatinine. This is a 35-year-old lady. Her creatinine is now 1.8, 1.9. She is going to get into a place where in another 3-4 years she's going to be on dialysis. Now you're telling her, look, this is not okay. You can't be taking Combi-Flams. I've had people with erosive gastritis who are bleeding, upper GI bleed is going on, they're getting endoscopy done, they're getting treatment for all that because of the analgesic usage that they have. I've had people who are taking ergotamine who've had a stroke because of the ergotamine usage. They've had MIs because of ergotamine usage. Now, if I look at the cost, I understand in our country it's always going to be a discussion, but at the end of the day, I think that you have to tell people the context that look, at the end of the day, the number of medications you take will go down, the number of complications you have will go down, the long-term benefits are going to be there, and I think that this is a very, very underused therapy in my mind. And I know that, like I said, I bring this out to you because at the end of the day, there are people who are suffering so much. I've had people who got recently married and they've had a lot of trouble with their in-laws. Because they think that they don't want to do anything at home because they have headache. I mean, it's a genuine concern, And so I'm saying that there are people who have to be told that there are options, and it's not magic. Not everybody is going to get super, but some people really remarkably get well. So I think that all of you are the people, like I said, who see much more. And I'm saying that think about this condition. If a person has headaches or migraine, ask them how many days they have in a month. First of all, the advice is to improve lifestyle, reduce caffeine intake, make sure that if there's an identifiable trigger, you avoid that. Even in spite of that, they are still having headache. Are they overusing medication? Understand whether taking how many in 1 month, kitne patte khatam ho jate hain. So I had a person who was doing about 20-30 tablets of Migraine a day, and she was up four of them in 1 day. So I'm just saying that these are things that it's not very hard. Kitne headaches ho rahe hain, kitni dawaiyan le rahe hain. Aapke basic lab parameters kaise hain. Then consider the outcome. So I think that this is something that I wanted to give this message to you, and again, That's the last slide, and thank you everybody again for a very, very nice learning. You will always bring me whenever I'm here. Thank you very, very much.
Thank you.
Take the mic.
Hello. He has very nicely and has talked very, he has explained everything on migraine and its treatment with this new injection medicine. But still, if there are some questions, I am asking the audience to please ask. And let us start with Dr. Tulsi. Thank you.
ये लाइट बंद कर दो, ये लाइट इसके आगे कुछ रख दो ऐसे।
So, thank you, Dr. Reddy. It's been a time since we connected, maybe because of the COVID, 2 years. Always a pleasure to listen to you, sir. So, the World Congress of Neurology last year said that if you add a CGRP monoclonal antibodies to botulinum toxin, it significantly, improves migraine. What do you say, sir?
So the CGRP molecules, which are basically 4 today, out of which 1 is there in our country, was approved worldwide in 2018. Now it's been about 4 years of usage in the world, and they are an effective form of therapy because they specifically, are no longer, see, all the other medications we use for migraine are repurposed drugs, like topiramate is an anti-epileptic, our propranolol is an anti-hypertensive, amitriptyline is an antidepressant. So these are all repurposed drugs which were used for migraine. They're not migraine specific. This is the first group of medication that have been developed for this. But I want to tell you that at the moment, the cost of that therapy in today's day and age is about 25,000 rupees a month for 1 injection every month, which you give separate. So I'm not talking about the cost. I'm also saying that even in the US today, you divide migraine into 4 types of migraine. One, which is called low frequency episodic migraine, in which you have 1 to 3 headache days per month. Moderate frequency episodic migraine, which is 4 to 7 days. High frequency episodic migraine, which is 8 to 14 days. And chronic migraine is more than 15 days. So CGRP antibodies, monoclonal antibodies, are used and approved for anybody who has at least a moderate frequency episodic migraine and has failed 2 therapies for at least 6-week trials. And in some places, insurance in the West insists that they should also have failed botulinum toxin. When you start using these therapies in conjunction, obviously my understanding is they'll get more effective. Because the advantage of botulinum toxin is that there is nothing systemic. You're giving it everything locally. So there is nothing that you need to worry about in terms of anything else. But in terms of using these therapies in conjunction, there are studies going on, but to my mind at the moment, sir, it's a fabulous thought and it will probably happen in the future, but it's going to be prohibitively expensive. That's my first thing to tell you. In terms of efficacy, you're completely right. We might have benefits of giving it.
So this is what the World Congress of Neurology said last year. And Dr. Reddy, I believe now the oral CRP antagonist is also available by the name of etigapan. Probably word on that?
So these are called G-PANTs. The group is called G-PANTs, and they are again used as oral. So these are called small molecules as compared to the monoclonal antibodies. Monoclonal antibodies actually target either the ligand, which is CGRP, or the receptor. The one that we have today in India is called Erinomab, which is monoclonal antibody. It's also called Subire in India. It targets the receptor. And CGRP ligand ko jo target karte hain, they are the other one. The G-PANTs is another group which is called the small molecules, and there is Erbo G-PANT. There are all these things now which are being approved in the US, And they are going to be good alternatives in the future for therapy. At the moment for acute migraines, yes.
So I was talking about the CGRP antagonist eticapan. It's an oral. It's just available since just over 6 months back.
Yes, sir. This is the GPAN. GPAN. This is not the monoclonal antibody, GPAN group. They also act via the same pathways, but they are under a group called they are called GPAN group.
Okay.
GEPANT.
I wouldn't know much about it, but Dr. Reddy. So talking about botulinum toxin, benefits accrue after about 7 to 10 days, peaks in about 4 to 6 weeks, and diminishes in about 12 weeks. So you have to probably repeatedly give these botulinum toxins every 3 to 4 months. What do you say?
So the trial actually used this every 3 months for 1 year. But what in our experience is that after 2 sessions, people do get relief, and after they have gotten relief, sometimes some people will push off their 3rd session. But the strict trial is to give every 3 months. So like I said, my only request is there are people who can afford these therapies also, who are sitting at home and suffering, taking a lot of medication. At the end of the day, I'm saying that you look at the therapy. Suppose I give 4 sessions of botulinum toxin in 1 year. It is 1,20,000. It's 10,000 rupees a month. It's not cheap, but it's not out of the ordinary for many people in the city. Let me also tell you that, for the kind of problems that they're suffering from every day.
My last probably 2 questions would be, first would be regarding neuromodulation. See, how do you see the future of neuromodulation? We have at least 3 FDA approved neuromodulations now, non-invasive, talking about the external trigeminal nerve stimulation, the TMS, and the VNS.
So, neuromodulation devices, there is a device now called Kefali, which is pressed on the head. There is another device called Gamma Core, which is used for vagal nerve stimulation here. So these devices have been approved by the FDA. Basically what they are doing is they are targeting the gate theory of pain. All pain signals go to the brain. Okay, just broadly speaking. All these pain signals, when they are going to the brain, imagine that there is a virtual gate in the brain. The virtual gate allows only one signal to go at one time. So अगर पेन जा रहा है और आप कोई भी काउंटर सिग्नल भेजते हैं, तो the pain reduces. Now I'll explain this to you. Suppose you put a hot pack where you have pain. Heat will start going, pain won't go. If you put a cold pack, cold will start going, pain won't go. If you get hurt, the first thing you do is you rub yourself. When you rub yourself, touch sensation start going, pain doesn't go. So if you put any gel, what the gel does it heats up your skin. When that heat starts going, pain won't go. So all these mechanisms are counter irritation mechanisms. So they break the cycle of pain, they allow the brain to get rested. If the brain is getting this incessant barrage of pain signals, after some time the threshold for pain in the brain starts falling. अगर आप किसी की रोज पिटाई करोगे ना, तो वो आपको देख के रोना शुरू कर देगा. You don't have to touch it. So the brain is like that. So the brain is getting these repeated signals. So when you block that signal off for some time, then what happens is the brain gets stronger in that period of time. So acupuncture, acupressure, all these, you get a headache and you do this, you feel better. So when you talk about neuromodulation and all these techniques, they are basically modalities where you're using a counter-irritant mechanism to try and break the cycle of pain, and it's not a bad thing to do. But at the moment, none of these devices are yet freely available here. So I'm hoping that they will be an additional, and of course, they'll reduce the pharmacological burden of what patients take, so that's also a great advantage.
Sir, my last question. So, migraine with comorbidities. See, it's so important to recognize migraine with comorbidities, as if you have a migraine with depression, probably you need to give antidepressants. If you have migraine with probably a GI problem, Dr. Shubham is here, would like to avoid NSAIDs. So if you have migraine with probably acute ischemic stroke history or ACS, probably like to avoid triptans because of the increased thrombotic events associated with triptans.
Absolutely, I completely agree with you.
Thank you, sir.
Sir, after a wonderful talk and exhaustive questions, sir, very small questions from my side. Firstly, sir, as you said, botulinum was used in hyperhidrosis also. So have you used yourself, and how many injections are given in that site?
Hyperhidrosis depends on the site.
Okay.
So a lot of people come with palmoplantar hyperhidrosis. So for that we tend to give, you have to give multiple intradermal injections. So it is little discomforting, but it works very well. Axillary hyperhidrosis, sometimes you have Fraze syndrome where you have sweating when you're eating. Suppose you have crocodile tears after a Bell's palsy, you can give it into the to the lacrimal glands, and you can actually reduce the cells. So it's been used for any areas where there's excessive secretion. Yes.
Duration is again 12 weeks.
Usually it lasts for about 12 weeks, but very small amounts of unit are used there.
Sir, have you used it, or is it usable in status migrainicus?
Status migrainicus?
Yeah.
Status migrainicus is actually chronic migraine.
Yeah. So is it?
It is very useful. Fantastic. It works very well.
No, but BT to be effective probably takes about 7 to 10 days. How would you like to use in acute attacks?
No. See,
Treatment of choice would be to give IV valproate or hydrohydratamine subcutaneously.
no. There is no question of not using those other agents. You are using it in conjunction with these other.
That be effective in
It
acute?
will be, because you are giving them something so that they are not going to get attacks in the future. No. See, if you
Agreed,
have
that's for prevention, sir. We are talking about acute attack treatment.
even an acute attack treatment, IV valproate is going to be a preventive drug. Valproate is, all these are used for acute migraine. One set are acute for acute will be all our triptans, you will load sometimes with prochlorperazine. But in these situations, if a patient has come with these things, there is a good case to want to use us to start a migraine. It's like, I'll put it this way, you have an MI, you're going to stent this guy, you'll put him on aspirin so they doesn't get a heart attack again. So is it not going to be giving aspirin, because aspirin to 3 mahine baad kaam karegi.
I understand, sir,
So-
for prevention.
I will request Dr. Tulsi to bring his own mic. He snatches mic from me. Sir, sorry for the interruption. Sir, for the injection given to the ladies through the hairs, so is there any preparation required for shampoo?
Just cleaning with, I just clean with a little bit of spirit. That's all I do, nothing else.
Oh, no problem. Sir, are there any predictors or the markers or the factors which decide that this patient will be benefited more than the non-responders?
Patient selection is very important, you're completely correct. It's also people who have tenderness. If a person has very specific tenderness over his temporal muscles, over his frontal muscles, or some people will come and say occipital, they have a very, if they touch also they get it. That is one of the predictors. So these are things that help. If they have very typical history of migraines also, people do very well. If you have people who have comorbid depression and there's confusion about those things, sometimes that can become a challenge.
Sir, like Dr. Tulsi's last question, mine is a real last question. Sir, medicine overuse headache. So as you told that this happens with the overuse of medicine used for headache.
Correct.
So if analgesics are used for other pains, so is there any chance of having headache from them also?
So that's very
Because the
interesting
same
question.
medicine.
Very interesting question, sir. It's been seen that people who have used chronic pain medications for, let's say, rheumatological diseases, the people who get MOH are people who have migraines. So that has also been looked at, and you're very correct about that. So if you have a person with rheumatological disease who does not have migraine as compared to rheumatological with migraine, if they use MOH, it's more seen in that group of patients.
Sir, Dr. Palvakar, can I have the mic?
These are the mic.
Yeah, thank you. Anyone has a question at the back? Dr. Suril, sir.
Yes, sir.
Can we use it for chronic fatigue syndrome, especially in the muscles of posture?
Chronic fatigue syndrome actually is in the spectrum of fibromyalgia. It's a sensory disturbance where they have, a lot of aches and pains which are disproportionate to anything that you find. To my knowledge, I don't think botulinum toxin has been used for that situation.
Sir, you mentioned a lot of medications for migraine. We have heard you multiple times on migraine. and also on the usage of BOTOX. You mentioned prophylactics like ergotamine for acute as well as for prophylaxis. You mentioned Ciplar or beta blockers. And you mentioned, you had told us about divalproate sodium, and I know one of your very favorite brands writing topiramate for prophylaxis, and also tryptophan.
Right.
Sir, at what stage do you decide that this is a candidate for BOTOX?
So I look at patients who have clearly qualified. So we must have a patient who has at least 15 days of headache. And I say that 15 days of headache for 3 months in a row, out of which 8 days must be typical headaches. This is the criteria they use. Now, I'm not to say that if somebody says I have only 12 days, he is not a good candidate. But I think that I look at people who are typical migraineurs. They give me all these, you can understand from the history, this has been going on for a long time. Some people have what we in the past used to call a transformed migraine. Earlier it was once a month, then became once a week, then became twice a week, then became 3 times a week. And slowly it sort of increased to a point. So these are the people that I use it for. And many of them have tried and given up, oral medication. I want to tell you that there are studies in the US. There's an, American migraine study in which they looked at the compliance, and they found that less than 16% people will use the medications for over a period of 6 months or 1 year. So even if you start these medications, let's say assume that they are efficacious, which they're not really. Even in that group, there's a very small number of people who take it. And so why don't they take it? Because 1, they feel it's not efficacious. 2, they feel there are side effects. So they don't understand that this was. So for me, I think that even the burden of having to take a medication like this is a challenge. You have to keep going on taking this and that, So here, for an appropriate patient, this is an excellent therapy. And I sincerely believe that, it's important to remember that ये है. Don't sort of think that somebody's going to make a rose headache हो रहे हैं. Ask them, rose headache हो रहे हैं. कितनी बार हो रहा है महीने में, आप लिख के दो एक डायरी में. और कितनी दवाइयाँ ले रहे हो आप ये बताओ मेरे को. And अगर वो आप देखते हो कि this person is getting to a phase where there's a problem, then they should be offered this. And we can figure out what needs to be done and how to do it for these. If there's an affordability issue, we can always think about it. But we can waive off our injection charges. There's no problem. It's all right. It's not such a big deal.
Sir, one of the criticisms of botulinum therapy has been that it is not a permanent therapy, and one has to repeat it, as Dr. Tulsi already asked the question.
Right.
Sir, how long can you go on repeating this? I'm sure at certain level you would say, no, I don't want to give it anymore.
There is no downside in the sense that apart from the fact that after you give it for a certain period of time, the muscles which you are giving it into can atrophy a little bit, because obviously they're not, you're giving a neuromuscular blocker there in that sense. But apart from that, there is nothing to worry. It's not being systemically absorbed. So if you need to give it, it can be given. We have so many people with cervical dystonias, with other indications for BOTOX, who are taking it for 10 years, 15 years. There's no problem. There are no new signals that come up on long-term follow-up. It's an absolutely safe medication. That's no problem with that.
Sir, just a related question, not related to migraine, but to the muscular irritability. We know that motor neuron disease is one disease wherein we face a problem of muscular fasciculations. Is this also a good alternative, the botulinum therapy, for fasciculations?
No, G, because the pathology of fasciculation is different. And actually in most patients with neuromuscular disease or motor weakness, the chances of botulinum toxin worsening the motor weakness will be there. So, but the absolute contraindications for giving botulinum toxin are myasthenia gravis. So you don't want to give it in that place because obviously neuromuscular junction is all affected. And again, in motor system diseases, you would want to avoid it. So you don't want to give it in this case.
Right, sir. Sir, we have a lot of people in our clinical practice with blepharospasm. Is it an
excellent alternative? It's the best therapy. I have a security guard who got beaten up by women because he keeps doing that. So I had to give it to him. He was very happy because he says कि मैं जब ladies से बात करता तो मैं sir ऐसे करता. because otherwise it will keep going like that. So it has happened, sir. It's a very good alternative.
Sir, I understand that the very first patient that you told me about botulinum was a patient from Nizamuddin, if you would remember.
Yeah.
Was a teacher from Aligarh.
Correct.
And she got botulinum from me. And I was so confused when you said that she's got cervical dystonia, Dr. Chauhan, and I need to give her botulinum. And when she got the first dose, she was benefited. And then she came for repeat visits to you. So it was very exciting. Your experience of last 15 years of botulinum, can you just summarize it for us?
So, like I said, so any of these motor things, so one is hemifacial spasm. We see a lot of patients with one side of the face spasming. That's a very good candidate for this thing. For blepharospasm, for chronic migraine as we've discussed today, for cervical dystonias, for spasticity. So post-stroke spasticity, post-cerebral palsy spasticity, these are indications that we are routinely using it and patients do very well. It's also sometimes, like I mentioned, for hyperhidrosis, a rarer thing. And there are certain rarer movement disorders such as writer's cramp. Some people will come and say that they can't write. They can do everything else, all the acting. This is called a task-specific dystonia. So in writer's cramp also, none of the other medications which are there will work at all in these conditions. So if you have any of these conditions, botulinum toxin is the #1 choice, and if you do identify these people, this is the best way to treat them. They may not completely recover, but there's no point taking an oral medication that doesn't work at all. There's no point.
Sir, a very quick question. The pathophysiology which we are going to target with BOTOX is targeting the nerve endings or the motor points?
The nerve endings.
And that will cause the relaxation.
Correct.
Vascular, so you're trying to work on the vascular theory?
So it's basically what it does is that you're at the neuromuscular junction, the release of the acetylcholine is what is being affected eventually. So there are sensory systems also through which it acts. And the sensory system is not so well elucidated as the motor system. Right? But it is clearly seen that it works very well through the sensory system.
Reddy, are you including these tension headache patients, a chronic daily headache in these groups?
So that's an interesting thing. So a lot of people actually, when they talk about tension headache, there are people who in the American Headache Society and people who are really working only on headaches all the time, who don't believe that there's something called tension headache. They say that all headache is migraine. That when you call it a tension headache, it is a migraine which is actually worsened by tension. So tension is that trigger. To start calling them tension headaches, there's like, I know a guy called Dodek, he was the president of the American Headache Society. I asked him about tension type headaches. He said, I can count the number of tension type headaches I've seen in my life in both fingers of my hand. So, I mean, this person doesn't know anything about headache. So he's not convinced. So the kind of criteria that they have for tension type headaches and all that, actually you see most of these people are migraines. Yeah. And they have actually gotten worse and they've reached a point where there's certain characteristics of headache which is continuous, tightness, this and that, which sort of tend to call it a tension type headache, but it's not truly that. It's a migraine exaggerated by tension.
Have you seen worsening of symptoms post botulinum?
Not even once. Never.
I have seen
of headaches, sir?
patient going through hell
For headache.
after botulinum toxin.
Or for which one, sir? For migraine?
Whatever you are saying, the chronic daily headache or
For the migraine. Or not for cervical dystonia, no? So you see, a lot of time what happens is, you have to understand that when these people are coming, a person is taking 4 vasograins a day or 8 vasograins a day. जब हम उनको बोटॉक्स लगाते हैं, हम बोलते हैं कि ये सारी दवाइयाँ बंद कर दी हैं. I can't be allowing them to take 8 vasograins a day. So that is like telling a smoker who's smoking 60 cigarettes to stop smoking. For 10 days, 2 weeks, 3 weeks, they'll feel miserable. Whatever you do. But that is a process of de-addiction, no? I mean, you're like, if you don't do that, people are going to be taking the medication. It's just not acceptable.
I'm not a neurologist, but headache patients whom I label migraine.
Yes.
There is amazing response to amitriptyline.
Yes, many of them do. Absolutely. It's not because you're...
Only thing is they put on weight.
That's a good option. It's a very good option.
Friends, I think Dr. H.P. Singh sir has a question. Dr. H.P. Singh sir interacted with Mr. KCR, and Mr. KCR sent him a message that the bouquet he gave him is still has the fragrance. Proud of him. Yes. And can you believe KCR has carried it back to Telangana, and he sent him a message.
सर आज आपने कुछ किया तो नहीं है?
मैं सर अभी करूंगा, अभी कुछ किया नहीं है। सर प्लीज,
फिर ठीक है
सर प्लीज।
Sir, I have a very small question, sir.
सर प्लीज।
Is there any definitive, again I repeat, definitive management of migraine by drugs or BOTOX or any modulation?
Definitive therapy.
So when you say definitive therapy, these are all preventive therapies. They are not cures, no? None of them are cures. So if you mean definitive therapy is a curative therapy, no, there is no curative therapy. Curative
I think friends, we had a wonderful session with wonderful questions from Dr. JPS Tulsi and Dr. ML Kadra sir, and Dr. Sunil Kapoor sir pitching in with some of his own, and Dr. H.P. Singh of the KCR fame also putting some questions. Sir, we are proud of you, sir. Jokes apart, the way you handled KCR sir in your Mohalla clinic and the questions he asked. And sir, the best thing I liked was your simplicity and your spontaneity with the answering of their questions. No jokes. I just love you for that, Dr. H.P. Singh sir. I'm sure you would have many questions answered today. We have some wonderful physicians, neurologists in the group, and a lot of people who have faced the challenges of, I think migraine is one of the most critical challenges that a physician faces in practice. Dr. Mangla sir said tryptomer has a wonderful response. I would say I learned from Dr. Reddy sir himself in 2006 that you put your patients on dopamate, wonderful response. Divalproate sodium, wonderful response. Ciplar or Inderol, beta blockers, wonderful response. But at one point in time they are all bound to fail, and that is how we come to the theory of botulinum. You have all cases of failed therapy of migraine, and you can refer all those cases to Dr. Rajashekhar Reddi. Not that he is asking for it, I am recommending you send all those cases for botulinum therapy, at least to experience benefits of botulinum therapy. भाई जब तक भेजोगे नहीं, जब तक मरीज लगवाएगा नहीं इंजेक्शन, तब तक कैसे समझ में आएगा इसका फायदा है कि नहीं.